The frequency of the coagulopathy in COVID-19 really depends on how you define coagulopathy in COVID-19. So if you define it based on laboratory parameters, the high D dimer and the high fibrinogen, the vast majority of our patients have coagulopathy. But if you define it based on thromboembolic events or microvascular thrombosis, the rates really depend on the study that you look at. But for thrombotic disease, that is anywhere from the high teens to upwards of 69%. And with microvascular thrombosis, it could be as high as 87%. And the second question, in terms of who is at greatest risk, I think that is not well elucidated quite yet. Our data does suggest that endotheliopathy happens regardless of the severity of disease. We see that in patients who have COVID-19, who thankfully don't need to be hospitalized in the ICU. They still have to be hospitalized on the floor, but not in the ICU. So we would predict that endothelial markers like high von Willebrand factor may predict those at the greatest risk of severe coagulopathic disease. Well, we do know that the virus infects endothelial cells via the ACE2 receptor. And we know that there are histopathologic changes consistent with endotheliitis in these patients. What our study shows is that these endotheliopathy changes happen not only in severe disease in those who are in the ICU, but also in less severe disease in those patients who are on the floor. And based on other models where endotheliopathy plays a role, we would predict that endothelial injury and activation of the coagulation are intimately linked. The hyperinflammatory phase is a well-known phase of this disease process. And the coagulopathy often seems to go hand in hand with it. It's a little bit of a causality dilemma because, for example, one of the key mediators in the hyperinflammatory phase is a cytokine called interleukin-6. That is released from endothelial cells in large part. And so the question becomes, is it the virus that is infecting and damaging the endothelial cells, or is it the hyperactive immune system that is damaging the endothelial cells? We don't know that quite for sure yet. We are here at Yale working on figuring out the sequence of events. I should mention that there are important studies showing complement deposition early on in this disease process, and we believe that may be a critical part that is happening upstream of all of these coagulation issues. The big thing in the literature that is not always fully appreciated is that there has been proof that prophylactic anticoagulation certainly benefits patients as compared to no anticoagulation. This is for patients who are hospitalized. With that being said, in any health system and country in the world where prophylactic anticoagulation is given to all or most hospitalized patients, that data doesn't really help us further. So there are a number of recommendations and by societies, including the American Society of Hematology, the International Society for Thrombosis and Hemostasis, that outline the benefit of prophylactic anticoagulation, again, as compared to no anticoagulation. The bigger question becomes, what happens with intermediate dose and full dose anticoagulation? And right now, we don't know enough. Clinical trials are ongoing because the safety and the efficacy of this approach hasn't yet been vetted. There are a lot of medical centers in this country, in the United States, and around the world that are using empiric increased intensity anticoagulation that's based on D-dimer elevations, and then a clinical suspicion for a VTE event. But again, we need more information and more data before we can know for sure exactly what their benefits and the risks are for that approach. And also, I should mention that some institutions are utilizing antiplatelet agents and endothelial cell modifying agents, ours included, and these are also being studied in clinical trials. Identifying high risk populations is crucial because we need to know who to monitor in the hospital for a longer period of time. And knowing who's at higher risk may give us an opportunity to increase their anticoagulation or utilize things like antiplatelet agents and agents that protect the endothelium. So, the one coagulopathic biomarker that has been shown over and over to be predictive of mortality in multiple studies is the D dimer. Now, our data from our study would suggest that more specific markers of endotheliopathy, like von Willebrand factor and soluble thrombomodulin, might be adjunctive labs to further identify the highest risk patients. And of course, other clinical parameters may be helpful as well.